Good morning. All right. Mm, Yeah, I guess give it 1 minute and we'll get going. All right, I see everybody's here, so let's get going. Okay, so moving along in our antiarrhythmic agent description and discussion, amiodarone. Amiodarone is the other class 3 agent. You recall that we last week we spoke about sotalol, the other class 3 agent. So these are agents that prolong the action potential plateau without affecting phase zero. So the effect of a class 3 agent is the dotted line. So you see phase zero is not particularly affected, but it prolongs out the action potential. This is the effect on the electrocardiogram, showing that it can widen it and lengthen it a little bit, but importantly, it affects repolarization, causing a prolongation in the QT interval. And that is, in fact, how one of the ways in which it is an antiarrhythmic agent by prolonging both depolarization and repolarization. And this is just an example of how a little bit is good, but a lot is bad. Okay. Unlike other agents, the effects of amiodarone are felt at all the levels of the heart, and it can prolong the action potential in atrial muscle, ventricular muscle, Purkinje fibers, and accessory pathways. Additionally, it can have direct effects on the SA and AV node, and it reduces sinus node automaticity, and it will slow AV nodal conduction. And because of the half-life of this agent that sticks around so long, oftentimes you'll see that our transplant colleagues, in our case, Dr. Lamore and Dr. Bonsall, don't generally like us to use this agent on anybody who's going to be transplanted because the impact can be quite significant on a transplanted heart. Again, it causes widespread changes in the electrocardiogram. It causes sinus bradycardia. It causes prolongation in the PR interval, a slight increase in the QRS width, but most importantly, QT prolongation. And that's the thing that we're mostly looking at when we're getting 12-lead electrocardiograms on a daily basis as we are loading somebody with amiodarone and in follow-up. Is a little bit is good, a lot is not. Clinically, amiodarone can be used for many different tachycardias. It's particularly effective for VT, and in fact is recommended by PALS as the first-line agent for VT. It can be used for postoperative junctional ectopic tachycardia, as some of you know. It's a good agent for the treatment of or prevention of SVT. And the alpha blocking properties cause vasodilation and afterload reduction, and this may be why it's acceptable for patients who have poor function. It is actually a potent negative inotrope in experimental studies, but perhaps because of its vasodilatory and afterload reduction features, it may actually be why this agent is tolerated. I think it was actually introduced in the early 1970s and late 60s as an afterload reducing agent. And it was only after it was used for a short while that it became clear that it was a very weak afterload reducing agent, but it was a very potent antiarrhythmic agent. Traditionally people think of amiodarone as being like the least negative inotrope. That actually is completely false. It's one of the most potent negative inotropes. But again, it's thought that maybe the reason it's tolerated, even in patients with bad function, is because it does have some positive effect on hemodynamics other than the negative inotropy that it's associated with. One of the benefits of amiodarone is it can be administered both orally and intravenously. So for oral loading, we would typically give 10 milligrams per kilogram per day over 2 weeks, 1 to 2 weeks. And then the typical dose is 5 milligrams per kilogram per day, typically given once a day. Sometimes you'll see that we give amiodarone when we're loading in a BID fashion. There are two reasons for this. One is that we can give higher doses more quickly that way. Because you might ask, well, if the half-life is very long, and I haven't really said that yet, but the half-life can be as long as 45 days. It's a very, very long half-life. Does it really make any sense to give it twice a day? The short answer is probably not, but one of the reasons that I prefer to give it twice a day as a load is because it can cause nausea in patients. So by dividing the dose in half, patients are less likely to have that side effect. I would remind that for VT, the treatment dose is 20 milligrams per kilogram per day as a load, and then the chronic dose is 10 milligrams per kilogram per day. People sometimes think that everybody gets 5 per kilo, but 5 per kilo is really for supraventricular arrhythmias, 10 per kilo for ventricular arrhythmias, and the loading doses are double that in both. In terms of IV loading, the traditional recommendation would be that for JET or for SVT, you would give 5 per kilo over anywhere between 20 and 120 minutes, followed by 5 milligrams per kilogram per day. This is for children. For VT, again, we would give 5 per kilo as the initial load. And then the standing dose would be 10 per kilo per day. And you can always, of course, give more amio if you don't have effect. And it's important to remember that because the half-life of the IV agent is substantially shorter than the oral agent, one needs to overlap IV and PO when transitioning from a patient who was treated acutely with IV amiodarone and then transitioning to oral amiodarone. So typically, if somebody, for example, is getting 10 per kilo per day of IV amio, one would also start 10 per kilo per day orally. So the patient would basically be getting 20 per kilo per day, but only for a day or two. Then you could sort of wean down the IV over a 24 to 48-hour period. And that is generally a better way to do it than to just turn one off and start the other, because oftentimes the arrhythmia will recur if you do that. Okay. There are a number of serious side effects associated with amiodarone. The most important one for us is that of hypotension and cardiovascular collapse, which is seen in between 1 and 5% of small infants who receive a bolus of intravenous amiodarone. And it's believed to be due to the alcohol component of the formulation, which is a chemical called tween 80. And this is an idiosyncratic reaction, and it can happen in any infant. And when it happens, it can even be as bad as requiring ECMO support. And so one should really always think very seriously about using this agent. This agent has absolutely saved many, many people's lives, and it's a very good medication, but it does carry this risk, and it is real. And somebody like Ivana, who's going to be doing cardiac critical care, you will see this in your career. It's a virtual guarantee. And so one of the reasons why sometimes I prefer not to use it in small infants is exactly for this reason. I feel like if there's an alternative agent that is not associated with this complication, I would rather try it if I think it's going to be effective. Another very serious complication of IV amio is that of phlebitis and chemical burns. So it's very sclerosing to peripheral veins. And if one is giving it peripherally, it's safe to give peripherally, but you really need to be sure that you're administering it through a good IV. And the likelihood is high that within 24 to 48 hours, you're going to blow that vein just because of the nature of this agent. So when someone is receiving amiodarone peripherally, intravenously, one should really be very aggressively checking the IV site. I have seen many children over my career who have had chemical burns requiring even skin grafting from chemical burns from amiodarone, which is why my general approach is that if someone is arresting, of course, you give it IV peripherally, but you should try to transition it to a central line as soon as you clinically can. And if you cannot, then one needs to be very, very careful about monitoring peripheral IV access sites where this is being administered. And if a patient is complaining of discomfort at the site, one should take that very seriously. Other complications of amiodarone include proarrhythmia, just like in any other antiarrhythmic agent. it has the potential for being pro-arrhythmic. One of the things about amiodarone that make it so ideal and why it's become so ubiquitously used is that it actually has a very good track record for not being especially pro-arrhythmic. Let me contrast that with, say, flecainide, which has a very high pro-arrhythmia rate associated with it compared to this. Amio almost never causes arrhythmias in patients if it's dosed properly. So that's one of the major benefits of this agent. It can cause corneal microdeposits, which can be seen on a slit lamp examination by an ophthalmologist. And generally, uh, generally, they do not cause dysfunction of vision at all. Really only an issue on the slit lamp, and they resolve with discontinuation of the agent. So the reason, though, that we have people go to the ophthalmologist is because it can very rarely cause retinal problems. It's extremely uncommon, but it does happen on rare occasion. The vast majority of patients, though, only develop the corneal microdeposits. And again, it does not affect vision, and it typically goes away when you discontinue the agent. Thyroid dysfunction, whether hyper or hypothyroidism, is very common with amiodarone. So one needs to monitor this in patients who are on it for a chronic setting. Pulmonary interstitial fibrosis, very serious, irreversible complication of amiodarone. I would say perhaps the single most important reason you cannot leave somebody on amiodarone indefinitely unless there's extenuating circumstances, because this is a complication that is not reversible. And it is thankfully a complication that is almost always seen with chronic long-term use of amiodarone. So you've, of course, seen that we will not uncommonly treat somebody for something like 6 to 12 months with amio, particularly small infants. But one of the reasons, amongst many, that we will discontinue the agent by about a year of age is because of concern of development of these longer-term complications. It can have effects on hepatic function and hepatitis. Chemical hepatitis is possible. And so one should be monitoring LFTs with your TFTs. Long-term use can cause peripheral neuropathy. It makes the skin very sensitive, and so anybody who started on amiodarone should be very strongly advised to be very aggressive with sunscreen and avoiding direct sunlight if possible. And finally, it can cause a bluish tinge to the skin. And again, another reason, which is in part due to the photosensitivity, and so one should be very careful about staying out of direct sunlight or using very aggressive measures like high SPF sunscreen to avoid that complication. This screen is very important in terms of your board examination one day, which is drug interactions with amiodarone. It is a cytochrome P450 inhibitor. This first one is very important, that it can lengthen the INR by reducing clearance of warfarin. So patients who are on warfarin and amiodarone should have the warfarin dose lowered. Typically, we'll drop the dose in half when you start amiodarone and monitor INRs until you know the exact degree to which the amiodarone is affecting the clearance of the warfarin in an individual patient. It can double digoxin levels. So if you have a patient who's on digoxin and amiodarone, the digoxin dose should be halved. And if one is concerned that they're not getting an adequate dose, you can always check a digoxin level after you've been on the two agents for a while. Always, you should be careful in using other agents in an amiodarone patient that can prolong the QT. And so you should, carefully vet these agents. And if they are deemed to be critically important for a patient, then one should monitor the QT interval carefully in a patient who is on more than one QT prolonging agent. And then there are multiple interactions with other antiarrhythmic agents. And so quinidine, procainamide, phenytoin, and flecainide levels are all increased with amiodarone. And so all should be lowered when you're using with amiodarone. And so some of you have seen that we particularly use the combination of amiodarone and flecainide for patients who have very serious arrhythmias that are very difficult to control in the newborn period. A common example would be somebody with an ectopic atrial tachycardia. You may notice, or you should pay attention to the fact that typically Barry and I will start very, very low doses of flecainide, maybe even half of the starting therapeutic dose of flecainide, on the theory that the amiodarone will increase the level of flecainide, and so a little bit goes a lot longer or a lot farther. And finally, amiodarone can potentiate beta blockers and calcium channel blockers. So one should be careful with that in terms of sinus bradycardia, hypotension, and also AV nodal conduction. The combination can cause a pretty long PR interval. Any questions? Okay, so if not, then I guess we'll go forward to some more potpourri of questions in EP. Okay, so this is from an ablation of SVT. And based upon this image, do you have any thought regarding where the arrhythmia is arising based upon this image? So I'm going to ask Dr. Mukhopadhyay if she has any thoughts on this. Katoki?
Good morning, Dr. I'm sorry. Um, um, I think based on this, it's a coronary sinus catheter, so it's a left-sided pathway.
That's correct. So this is a transeptal sheath across the atrial septum. This catheter, as you said, is the coronary sinus catheter that in this particular case has been placed from above, presumably from the internal jugular vein. And the ablation catheter is pointing just distal to the distal pair of the coronary sinus. So this would be like a left lateral accessory pathway, presumably. Or it could be a left lateral ectopic atrial tachycardia, I guess. And when electrophysiologists describe the location in their reports, we think of the mitral annulus, which is roughly in this dimension, in this image, like a clock face, with this being 12 o'clock and this being 6 o'clock. So one would say, sometimes you might read in a report that the ablation took place at approximately 3 o'clock on the mitral annulus. That's what is meant by that reference. Okay, is in this projection, the annulus should be roughly in this direction, with the CS being the posterior aspect of the mitral valve. Okay, so this is a left lateral. And you could see why when pathways are located over here, which would be considered anterior and lateral, it can sometimes be challenging to ablate them. When a pathway is located over here, we have all of these electrodes which allow us to see relatively where the pathway is located. So if this pair is earliest, then we know that it's going to be somewhere in this general area. And we might even see that it's later here and earlier here. So it gives us a general gestalt of the area. It puts us very nicely within a 4 or 5 millimeter radius of where the pathway is. Once you go beyond the end of the coronary sinus catheter, we don't have the analogous diagnostic catheter there to help us. So if it's beyond this area, a pathway could be here or it could be all the way over here. And so one needs to go point by point with the ablation catheter and scan the entire area before one figures out where the pathway is. And you don't really have the confirmation of a coronary sinus catheter. So whenever we are looking at a left-sided pathway, one of the questions we always ask ourselves is the pathway bracketed by the coronary sinus pairs, meaning is it earliest between two of the pairs, which would allow the operator the opportunity to carefully move to the area that the coronary sinus is suggesting that the pathway is located in. This is one of the reasons why I prefer to put my coronary sinus catheter from above, as is in this image. And that is because, in general, the coronary sinus will go out a little farther. The catheter will go a little farther when you place it from the IJ than when you put it from the groin and then use a deflectable catheter to go into the CS. I'm sure you've seen both Dr. Love and I do it in two different ways. The benefit of Dr. Love's approach is that the patient didn't have IJ access. And so it's one less access to worry about, one less access to have discomfort from afterwards. But I have always felt that the benefit of being able to get the coronary sinus catheter out a little farther can be important, particularly if the pathway is located in this region here. It's not uncommon that a CS catheter placed from the groin might stop here just because of the way the angle works from coming from below and going across posterior and leftward. Any questions about that? Okay. Right. This is a 35-year-old patient with tetralogy. And my question for you is, what is this rhythm? Let's ask Dr. Marshall if she has any thoughts on this.
Good morning.
Good morning.
So first just looking, the ventricular rate looks variable, so not regular, but also slow.
Is it regularly irregular or irregularly irregular?
Irregularly irregular.
Thank you.
And then when you're trying to see if you're seeing a P wave preceding it, I don't see that. And with it being irregularly irregular, I would say this is AFib with a slow ventricular response.
I would agree with that statement. So is this something you would expect in a 35-year-old tetralogy patient, Molly, or is this unusual, you think?
I would think this is unusual in terms of, I don't know, like the patient's underlying history in terms of like, if they're, I'm assuming they've been repaired, but in terms of like residual deficits they have. But I would, if anything, expect right-sided dilation, which I think of atrial fibrillation being more a left atrial disease in terms of thinking if like from atrial dilation, if they have like significant PR or something, like think about right atrial dilation. But so to answer your question, no, this isn't what I would typically expect.
Well, it's good thinking, but it turns out that all atrial arrhythmias and SVTs in general are more common in tetralogy. You know, we always are worried about VT and sudden cardiac arrest in tetralogy, which is, of course, very, very, very important. But it turns out that if you look, atrial arrhythmias with time are far more likely than ventricular arrhythmias. And AFib, of course, is a common arrhythmia in healthy people, and it's even more common in patients who have congenital heart disease. And so you're right, atrial flutter is common, but AFib can also be seen. And as our adult congenital patients are aging and doing better, we're seeing that the sort of unnatural history of atrial arrhythmias amongst congenital heart patients. And what we're seeing is that they are being affected by these types of problems earlier than the general population. And so it actually is not very unusual that an adult patient with tetralogy might have AFib. I think perhaps at 35, that would be on the younger side, but certainly TETs in the 40s and 50s, like statistically, much more likely to have this than they are to have VT. Something like 30 or 40% of TETs over 50 have atrial arrhythmias of some sort. So it's a real issue. So patient comes in, they've never had this before. What would you do for this patient, Molly?
They're stable.
Yeah.
Okay.
But he intermittently feels palpitations, which is why they came in.
Gotcha. And you said they've never had it before?
To the patient's knowledge.
To their knowledge,
his knowledge, yeah.
And then do we, just in terms of history, do we know how long that they've been feeling palpitations for in terms of if they're
Says
able
he's
to
been feeling it
appreciate
on
it?
and off for the last day or so.
Okay. So would
Why
want
would the patient feel it on and off, by the way? Let's assume, just assume we had a Holter and we knew the patient had been in it for a week. Why might the patient say they feel it on and off if we have documentation that they've actually been in fib the whole time?
depending on the ventricular rate.
Yeah, that's exactly right. And so one of the things you always have to be concerned about when you're dealing with any patient with an atrial arrhythmia, and you ask the question, how long have you felt this? I'm sure the patients are telling us the truth. They may say 5 hours, 6 hours. But the reality is that what patients generally mostly feel is the feeling of tachycardia from rapid ventricular response. So typically, you see this tracing and the patient's heart rate is slow, as you said. But if this patient were asked to sort of climb 2 flights of stairs, the ventricular response rate might go to 180 or 200. And that's usually what patients feel. So, in fact, it's always interesting to me. You have a patient come in with an atrial tachycardia, and let's say you give them diltiazem to have rate control. As soon as you get rate control, the patient will tell you that they feel like they're out of it. They're
Mm-hmm.
not, they're still in it. So you always have to
Mm-hmm.
take with a grain of salt what a patient tells you. Now, there are some patients who are extremely good historians and can tell the moment they go into the arrhythmia, but a lot of patients cannot. In fact, a lot of people in general can't tell they're an AFib. This is one of the reasons why patients who have occult strokes need to have some form of ECG monitoring to look for occult AFib, because what's been determined is that a lot of people who have strokes actually are having little episodes of AFib, or maybe even are in it for a fair period of time and they don't have any idea about it. So anyways, okay, so you've asked the patient says, I think it's on and off for the last day or so. So what would you do here?
So with the duration of it, would want to make sure that it's a clot risk, as you're just talking about with strokes. So would make the patient like MPO, would plan for it's looking like we don't need to do rate control at this time, given the ventricular rate is slow.
Mhm.
And then would do a TEE, start them on AC, sorry, and then like heparin, and then would do a TEE to make sure there's not any clots.
That's right. That's exactly right. It's interesting, but today that's what we would routinely do. But it's only in the mid 90s or even the late 90s when people proved that a TE was adequate to rule out thrombus most of the time. Prior to that, a patient like this would be put on Coumadin and sent home and said, come
Mm-hmm.
back in 6 weeks. Because, there's a literature showing that if you're properly anticoagulated for 6 weeks, even if you have a thrombus in your heart, that it will dissolve. And so the standard old-fashioned way would be to just put someone on warfarin, get them therapeutic, give them 6 weeks or 8 weeks of it, and then just bring them in for a sedated cardioversion without TE. That would be done fairly commonly. And it is still done when you have like a sick patient in whom maybe a cardioversion would carry, a TE might carry risk or something like that.
Mm-hmm.
And anyway, we should always remember that the TE is not perfect. There are rare cases where they miss a thrombus, but the vast majority of the time they can see thrombus. And Molly, where's the most common place that thrombus is seen in people when they have atrial fibrillation?
In the left atrial appendage.
That's exactly right. And sometimes it's my impression that it can be difficult for the TE doc to tell because there could be a lot of pectinate musculature in the appendage in some patients, and so sometimes that can masquerade as a thrombus when it's really just a lot of muscularization in there. So the other thing I would say is I personally think it's always worthwhile to do a transthoracic echo. At least, I would always do one because We know that a transthoracic echo does not rule out the presence of a thrombus. One would never do a transthoracic echo and then cardiovert somebody. However, if you did see a thrombus, of course,
Mhm.
no, and you could just sort of stop there. And then you would have to do the old-fashioned approach where you would anticoagulate the patient and cardiovert at a later date. I think in the present era, most people would probably look with a TE even after the 6 weeks to be sure, but maybe not. I don't know. So anyways, that's how we would manage this patient. And I think with that, we'll stop at 7:30. I hope everyone has a good day. I'll see you and sign out in just a short while. Take care.
Thank you.
Thank you. Bye-bye.